So I'm cheating a little bit because I'm gonna actually go through what was the first half or so of my talk at San Antonio. For those of you who were there, and I suspect most of you probably weren't there, but for those of you who may have been there, like Kathy, you can just put your head down and fall asleep. And then I'm going to end with some highlights. And the highlights are really touching on some of the things that have already been talked about, but just sort of what I think are the big messages from 2016. And I have to say that I think that there were somewhat fewer messages in 2016 than in past years, and I expect a lot more in the years ahead. So I was a first-year faculty member in 1990. And just to take a little step back, this was breast cancer in 1990. 150,000 cases, 44,000 deaths. We viewed breast cancer as a single monolithic disease. Patients would say to me, "What kind of breast cancer do I have?" And I'd sort of either visibly or not visibly scrunch up my forehead and say, well, it's breast cancer. And it was stage 1 or stage 2 or stage 3. But we didn't have the ability to discern different types. Most cancers at that time presented as a lump or mass. Since screening was in its infancy, screening is a whole other discussion which we're not going to get into. Extensive surgery was often performed and resulted in both psychological and physical distress, and adjuvant chemotherapy and hormonal therapy were still relatively recent additions. In fact, when I started, the alert about chemotherapy and hormonal therapy for node-negative breast cancer had just been issued by the NCI. Treatment of metastatic disease was, I would say, fairly abysmal. It was limited, toxic, and largely ineffective. We had many hospitals filled with patients getting autologous bone marrow transplantation or subsequently peripheral stem cell support with high-dose chemotherapy for metastatic breast cancer, which led to horrific toxicity and ultimately, of course, was proven to be not ineffective, but no better than standard therapy and much, much more toxic. Women were scared, not that our patients are often not scared today, but they were more scared. They were often uninformed, and they really felt like victims. There were still many people who felt shameful about the diagnosis, and of course that sense of shame is still very common in many societies and many countries around the world. And breast cancer advocacy, which I think has been enormously helpful to the field and helpful to other fields in terms of advocates in other areas, was really in its infancy. So the progress over the last 25 years, well, clearly there has been a move towards far less extensive surgery. This was just touched upon in the last session. But the surgeons have progressively been trying to do less and less and less, including both less to the breast and less to the axilla. Of course, this does come at a time when there are more bilateral mastectomies performed than perhaps ever before. But that is largely not surgeon-driven. There has been a reduction in late radiation toxicity because of better planning, and what I think are far more convenient fractionation schedules. The advances in chemotherapy and endocrine therapy have been substantial, and there is, of course, the widespread use of anti-HER2 therapy. And whoever thought when the first study of trastuzumab was presented at ASCO in probably roughly 1998 that it would ever be such an incredible game changer. Not just trastuzumab, but trastuzumab and the subsequent drugs and the appreciation that suppression of HER2 throughout the course of a woman's cancer with metastatic disease was important. Oh, wait, I missed something. Can I go back? Maybe not.
Right click.
Right click. There we go. And therapy today, I think it's fair to say, is far more individualized based on disease, on stage, and on patient preference. We really have gotten away in a very gratifying way from a one-size-fits-all approach. And in the metastatic setting, we again have a number of new chemotherapy and hormonal agents. We have novel targeted approaches that I'm going to talk about later on, a plethora of anti-HER2 drugs, advances in local therapy with the advent and widespread use of SRS by our colleagues in radiation oncology, which has been particularly helpful for women who have brain metastases. Far greater attention to quality of life and symptom management. We no longer hospitalize people endlessly. And finally, after many years when we couldn't be convinced that we were really making people live longer, we have individual clinical trials that unequivocally demonstrate that survival is prolonged. So we've learned a lot about heterogeneity, and there is, of course, both heterogeneity across tumors and heterogeneity within tumors. I'm not going to talk about intratumoral heterogeneity. But when I think back over the last 25 years, and I think of the single observation that is perhaps most important, it's this observation that breast cancer is simply not one disease. This is a heat map from Chuck Peru and Sorley and colleagues that was initially published in 2001, separating out cancers into basal-like, HER2-enriched, luminal A, luminal B, normal, whatever normal is that we still don't understand. And even back then, with a relatively small data set, they demonstrated that these subtypes correlated with overall and relapse-free survival in patients. And the reason, in spite of the fact that this was a fairly small data set, it was, if I remember correctly, about 160 patients, and they saw these differences, is that these were actually all untreated patients, and treatment begins to mess this up. Not that we should avoid treatment, but they could see that these different subtypes played out very differently over the course of time. So we now think very clearly of breast cancer as a family of diseases which has come about because of not just the genomic data, but of the convergence of the clinical and genomic data. We're still uncertain about how many family members. At a minimum, there's HER2-positive disease, which probably in and of itself is made up of two different types, HER2-enriched disease, commonly ER-negative, but not always, and then luminal HER2-positive disease. There's the basal-like or triple-negative disease, which, as we now appreciate, is in and of itself 3 or 4 or 5 subtypes. There's low to intermediate grade ER-positive disease, which is commonly referred to as luminal A, and high-grade ER-positive disease, commonly referred to as luminal B. And superimposed upon all of this is probably some background of sensitivity to immuno-oncology agents. So how sensitive these various tumors are to those therapies that affect the immune system. And of course, we are, speaking of the immune system, beginning to pay more and more attention to differences in the host, differences not only about the immune system from host to host, but differences related to states of inflammation and obesity and exercise and psychological factors. But in spite of all of that progress, in 2016, this is where we are. There are 246,000 cases of invasive breast cancer in the United States alone, 61,000 new cases of DCIS, virtually all of which exist because of the widespread use of screening mammography. 40,000 deaths, so a slightly smaller number of deaths with a larger number of cases, so that suggests some amount of progress, but still way too many deaths. And something that I continue to be struck by as a clinician taking care of a fairly large group of women with metastatic breast cancer, is that there is still way too much suffering, particularly in the last 6 months of people's lives. And worldwide, we have 1.7 million cases per year and over 500,000 deaths. So in my view, there are three major challenges that we have to overcome. And I'm going to talk briefly about each of these, which include therapeutic resistance, overtreatment, which in some ways is the opposite. So therapeutic resistance means we need more, of course, or different. Overtreatment is how little can we do, and then the whole problem of health equities. So let's talk for about 3 minutes about therapeutic resistance. It is a huge topic. We could have an entire course lasting 3 days about therapeutic resistance in breast cancer, going through all of the known and potential mechanisms. This is the major cause of breast cancer death in developed countries. It is a problem for triple-negative breast cancer, luminal B breast cancer, and some subsets of HER2-positive disease, particularly women who have CNS involvement. It is much less of a problem for patients with luminal A disease. There has been a rapid expansion of our understanding of breast cancer biology, which should lead us to clues in the clinic. And this is where we critically need collaborative approaches that include scientists and clinicians and advocates, and the federal government and pharma, and where funding is absolutely critical. So let's just spend a minute, though, talking about a problem that our group has focused on for a number of years, as have many other groups around the country and around the world, and that's the problem of brain metastases. Brain metastases arise in about 50% of patients who have metastatic triple-negative and HER2-positive disease. They do arise in the context of luminal B metastatic disease, but are somewhat less common. And particularly in the setting of HER2-positive disease, where women tend to live a long time because of the effectiveness of anti-HER2 drugs on metastases outside of the brain, we run into situations with HER2-positive brain metastases where women are getting treated very specifically for these brain metastases, and where after an initial course of therapy they are coming back with progression after progression after progression. And this is a major source of morbidity, of shortened survival, and probably somewhere in the range of a third to a half of women who have HER2-positive breast cancer with brain metastases actually die a death that is related to those brain metastases. So let me just tell you for a minute about a little bit of the work that we've been trying to do. So this has taken a team of people. Jean Zhao is a laboratory investigator. Keith Ligon is a neuropathologist. Nancy Lin is my close colleague in our breast medical oncology group. And what we have been trying to do is actually develop an entire group of orthotopic PDX models by taking tumor, largely triple-negative and HER2-positive, that is resected from a woman's brain and injecting it into mouse brain. The tumor is luciferized to allow for imaging, and this then leads to a group of mice who can be, in fact, used to test anti-cancer drugs. And what we've observed to date is that taken through 2 passages, these tumors are faithful to the tumors that were in the host, that HER2 doesn't change, that ER doesn't change, that PR doesn't change. And in some of the experiments, we've been able to get some clues. Unfortunately, those clues have yet to translate into clinical trials, but we believe they will. This was actually looking at the combination of BKM120, which is a PI3 kinase inhibitor, which gets into the brain very readily in combination with RAD-001 or everolimus. And what you can see is in the treated mice, dramatic shrinkage of the tumors and improved survival. And it's our hope although we were very frustrated here because we actually worked with the company that made BKM 120 and begged and begged and begged for drug for 2 years, and frustrated that we never got it. It's now a drug that's not going further. But our hope here is that through this kind of work, we're going to be able to do more rational clinical trials, because the haphazard approach just doesn't seem to work. And there are many new drugs for HER2-positive brain metastases. Both neratinib and TDM1 have both been shown to have activity. ONT-380, which is manufactured by a company called Cascadian, is a drug that is now in randomized phase 2 clinical trials and has shown activity in the brain. It's a HER2-specific tyrosine kinase inhibitor with extensive penetration into the CNS. And there is great hope for both the PD-1 and PD-L1 inhibitors. But this is where we really have to bring our scientific colleagues close to our clinical colleagues so that they can work together and try to tackle this problem. So what about overtreatment? So overtreatment has been something I have thought about a lot for many years. And you could argue that overtreatment isn't really a cause of mortality, because we usually, thankfully, don't take people's lives when we treat them, but it's a cause of substantial morbidity. And in 2016, when I think about overtreatment, I think it's mostly a problem for patients who have DCIS and early-stage disease of specific subtypes. So given the higher mortality in triple-negative breast cancer and luminal B disease, those are not situations where I would be in a rush to worry about overtreatment. I'm worried in those areas about trying to make treatment better, and once it's a lot better, I'll figure out who needs less. But I think de-escalation of treatment is a priority in other situations who may do very, very well with less, and this really mandates some creative trial design, which I'll get to in just a minute. But first, what's the evidence for overtreatment? Well, so this is Joe Sperano's paper from the New England Journal in 2015, looking at the cohort of women who were enrolled in TAILOR-X. Remember, the randomized part of TAILOR-X has yet to come out, in spite of the fact that the trial closed about 6 or 7 years ago. But these are the women with recurrence scores of less than 12, 11 or less, who were enrolled in TAILOR-X. There were 1,626 women who had a distant relapse-free survival of 99.3%. And an invasive disease-free survival of 93.8%. Given the difference between the distant relapse-free survival and the invasive disease-free survival, I think we have to presume that most of those events, in fact, were contralateral cancers, which is certainly not a reason why we would give contralateral ipsilateral recurrences, not a reason why we would typically give a treatment like chemotherapy. So you could look at this and say this is a huge success, because we've now identified a group of women who can do well with hormonal therapy alone. And I do look at this and say this is a big success, but I also look at this and say this is a big missed opportunity. And it's a missed opportunity because if, in fact, with a score of 11 or less, the distant relapse-free survival was 99.3%, we got the cut point wrong. Because even if that number were 97%, you can be sure we would be saying that chemotherapy wasn't necessary. And undoubtedly, we can go to a substantially higher score and still have that same conclusion. Moreover, it's probably true in both node-negative and certainly 1 to 3 positive node patients, if not all node-positive patients. This is a smaller and perhaps somewhat less valuable study that was published in the JCO last summer. It's a German study that was called Plan B. And in this study, they took patients who had these very low recurrence scores, who had either node-negative disease or 1 to 3 positive nodes, and they simply assigned them to hormonal therapy, no chemotherapy. And what you can see is in that box that's outlined in black, that in fact, whether a patient had node-positive disease or node-negative disease, the outcome was very, very favorable. I realize that this is only through 3 years, but I suspect that the numbers are not going to change dramatically over the next couple of years. So avoiding overtreatment for luminal A disease, and I apologize, by the way, that these slides look a little not balanced to me because I was going from normal PowerPoint to this landscape presentation, and it doesn't quite work. I like them to be visually nice. Avoiding overtreatment in luminal A disease. In my mind, the question, and I thought Kathy posed this earlier very nicely and addressed these questions earlier, do any patients with favorable gene signatures need chemotherapy? If a woman has 2 positive nodes, does she need chemotherapy? If she has a recurrence score of 10 or 11, or in my mind of 15. And my answer is if she has node-negative disease or 1 to 3 positive disease, 1 to 3 positive nodes, she probably almost certainly doesn't. And I wonder about the patient who has a higher disease burden, although I typically still give those patients chemotherapy. Unfortunately, shaking my head as I turn the knob to walk into the room every time the woman comes back for her chemotherapy, I manage to stop shaking my head before I walk into the room. But we need to know what the appropriate cutoff is. And do patients with favorable signatures, for example, those patients who have very, very low signatures, are those patients who need prolonged endocrine therapy or not? And we need to answer those questions. This isn't just about luminal A disease, it's also about HER2-positive disease. Because as we know, many patients with HER2-positive disease are highly sensitive to anti-HER2 agents. So this is the study that, led by Sarah Tillany, that we did, a study of just over 400 patients with essentially stage 1 breast cancer. We included patients who had tumors up to 3 centimeters, but only 10% of the patients fell in that group. And it's basically a study of patients who had T1B and T1C node-negative cancers with a small number of T1As and a small number of T2s. Patients were treated with 12 weeks of paclitaxel, with 12 weeks of trastuzumab. We would have given it every 3 weeks if we were doing it today, and then subsequently finished a year of trastuzumab. And these are the updated results that are going to be shown at ASCO, but I'm not giving you enough to make you not want to go to ASCO or to break any ASCO rules. The 5-year disease-free survival is 96.3%, but the distant disease-free survival is substantially better, and there were only 4 distant recurrences in these 400 patients treated with a fairly kind and gentle regimen, no anthracycline, 12 weeks of a taxane, and we've continued to look at other regimens in that setting. But perhaps there's a subset of women who have larger tumors or node-positive disease who would fall into this group as well. So this is from our trial in the CLGB 40603 that Lisa Carey ran, that randomized patients to paclitaxel, trastuzumab, paclitaxel, lapatinib, paclitaxel, trastuzumab, and lapatinib. And I can tell you that all 3 arms performed about the same. There was not actually any benefit in that study, any statistically significant benefit for the combination therapy. But what we did see was that patients who had HER2-enriched disease, also as mentioned by Kathy earlier, had a much higher pathologic complete response rate. Now, we can all debate the value of pathologic complete response, and I am the first to tell you that I am not at all convinced that we can use PathCR as a surrogate for a result from an adjuvant trial. So just because there's a higher PathCR doesn't mean you should start using that in the adjuvant setting. But there is no question that on an individual patient level, PathCR leads to a better outcome. So if you take the individual patient who has a path-CR, you compare her to another patient who didn't, the average outcome is better for the first patient. This is from NSABP B27, which, as you remember, compared AC and AC docetaxel. Patients who had a path-CR are shown in the dotted blue line. Patients who didn't have a path-CR are shown in the yellow line. But the interesting thing is it actually didn't matter in this study how a patient achieved a path-CR. If the path-CR was achieved with AC alone, 82% 5-year disease-free survival. If it was achieved with ACT, 84% disease-free survival. So maybe we've been looking at the role of neoadjuvant therapy the wrong way. We've been looking for new treatment approaches based on higher rates of path-CR, and that hasn't really paid off. Look at lapatinib, which failed in ALTO. Look at bevacizumab, which failed in multiple studies. Both of those treatments, in at least several studies, had higher rates of path-CR. Perhaps instead, we should attempt de-escalation in those who have a path-CR, and at the same time, use the patients who don't develop a path-CR to evaluate resistant mechanisms and new treatments. So I have an alternative design to decrease treatment, assess resistant, and test new therapies. And this, of course, is a thought experiment. So imagine a patient population, and you give them a highly active targeted therapy. And imagine that some have a path-CR. Those path-CR patients get limited additional therapy. Perhaps they would get anti-HER2 therapy or endocrine therapy, but they wouldn't get more toxic therapy, and they are followed. And we confirm the fact that they do well. The patients who don't have a path-CR have comprehensive tissue and blood collection and analysis and are randomized to a standard treatment or an experimental treatment. And the sample size will depend on the confidence intervals for the phase 2 study, which is the group of patients who have the path-CR, and the phase 3 study of the high-risk patients. But unlike a study that randomizes the patients who get a path-CR, which would take thousands upon thousands of patients, this will take a smaller number. And in my mind, this is the kind of study that we have to start embracing. So just to end these 3 challenges, the last one, which is the biggest and the most difficult to fix, I'm confident that science can fix the first 2. I'm not confident that the combination of our government and social scientists and on can fix the problem of health equities. This is a major problem worldwide and results in countless unnecessary deaths. Race, poverty, limited education, lack of health insurance are among the many causes in the U.S. Less than optimal care can arise from almost anything that makes a person different, whether that's gender identity or religion or many different factors. And no one knows the percentage of unnecessary breast cancer deaths in the U.S. because of health equities, but the best guesses are that it's probably somewhere between 1/4 and 1/3. We know that racial disparities in breast cancer continue to exist. These are SEER data showing deaths in African American women versus white women. And this disparities issue also exists for both older women and for younger women. The 2 groups of patients in this study who had the worst outcomes were the very young and the very old. You have to be careful when you evaluate survival in the very old because, of course, they die for other reasons. But even when that is controlled for and you look at breast cancer-specific survival, there is still a difference. And the cost of cancer therapy is only going to make this worse. This table comes from my own search off of Google, gives you some sense of the cost of the drugs, or at least what I would have had to pay on a given day about 6 months ago if I tried to order them. This is from Peter Bach's talk. at San Antonio. As new drugs have come up, the costs have gone up and up and up and up. And talk about an expensive regimen. We're now testing a regimen in the breast cancer intergroup of chemotherapy, trastuzumab, pertuzumab, and an anti-PD-L1 agent. That regimen will be somewhere in the range of $400,000 per year. And so breast cancer is very heterogeneous, but you can also think of it in a very simple way. You can think of it as the good cancers and the bad cancers, because there are a bunch of cancers that are just very unlikely to threaten your life. All those luminal A cancers, which probably account for about 50% of all breast cancer. And then there's the highly proliferative cancers. And then that's across the top, and across the side in this 2x2 is optimal medical care available and optimal medical care not available. And if you have a highly threatening cancer and medical care is available, the outcome is often favorable. It's almost always favorable, if, of course, if the cancer is more benign behaving. But when medical care isn't available, we see just truly disastrous outcomes for the women who have aggressive cancers, and longer survival, but still probably ultimately poor outcomes for the others. So we do have these major challenges. I actually think that in the next decade, we can eliminate about half of all deaths, but it's going to take a lot of effort. So I'm going to spend about 5 minutes giving you my highlights for 2016. And I'm going to skip where Kathy so wisely already said the same things. Not wise because you agreed with me, but because you were just being wise. So extended AI therapy. Remember, MA17R was presented earlier this year, 5 versus 10 years of an AI. Although there was a few % difference in the curves, you have to squint pretty hard. And the number of distant recurrences in this roughly 2,000 patient study, the difference in distant events was 11 events. It was tiny. NSABP B42, same basic study design. And here, there was a little bit more of a difference, although officially the study did not meet statistical significance given the way that they had constructed the statistics in advance. And the difference in distant recurrences here was 5.8 versus 3.9%. Now, for a woman who is significantly intolerant of an AI, that's probably a pretty bad deal. If you're doing well on your AI, it's probably okay. The data study that looked at 6 versus 3 years of anastrozole. Here, there seemed to be a benefit for 6 versus 3 years, although this too did not reach statistical significance. And finally, the IDEAL study, which took patients and randomized them to 2.5 versus 5 years of letrozole, showed really very little. So my conclusion about extended adjuvant endocrine therapy is it's a little bit of a disappointment. Late recurrences, however, are real. Stage and grade are the biggest prognostic factors. Genomic signatures are also prognostic. It's unclear if they're predictive. And I personally, in spite of all the marketing stuff you're going to hear from these companies, I am not convinced that one is necessarily different from another in terms of predicting late recurrence yet. There are pros and cons of treatment. The most important con in my mind is someone not tolerating it. So who should receive extended endocrine therapy? I think we have data to support it now. We didn't used to have data, now we do. So I would say patients who have stage 3 breast cancer and are still fine after getting 5 years of an AI. Some patients with stage 2. For the most part, anybody with stage 1 breast cancer, I mention the possibility and I dismiss it. I'm more inclined to treat a woman who's tolerated therapy than one who hasn't. I am particularly inclined to treat anybody with 5 years of an AI who started with tamoxifen, and my ideal candidate for 5 years of an AI is a woman who was 46 and still premenopausal when she started her tamoxifen, has gone through menopause over the last 5 years, you're sure about that, is 51, I'm imagining you're sure, I'm not telling you you're sure. She's 51. That woman getting 5 years of an AI will get substantial benefit. In MA17, it was the women who started in the premenopausal period who got 5 years of an AI who got the biggest benefit. And I would not give anyone more than 10 years of therapy. Second big breakthrough of the year. This really, in many ways, echoed the previous work with palbociclib. This is Monalisa with ribociclib. But the data here looked just like palbociclib, another CDK4/6 inhibitor, showing that, in fact, these drugs clearly prolong progression-free survival substantially in women with ER-positive breast cancer. These drugs are here and here to stay. They're being tested in the post-neoadjuvant setting. They're being tested in the adjuvant setting in a large international study called PALACE. They have yet to show a survival difference. I actually believe that they probably will eventually. And they're important drugs, and they're probably going to be important drugs for HER2-positive breast cancer. And Kathy mentioned this as well, the anthracyclines. This was from ASCO, the ABC trials that looked to see if you could omit an anthracycline. And guess what? You can't. You can in some people. But in the ER-negative patients, the patients who are most sensitive to chemotherapy, where we don't have other therapies, in fact, the ER-negative is shown in the top part. You can see the 4-year invasive disease-free survival, an absolute difference in patients with node-positive disease of greater than 10%. And so particularly for those patients with triple-negative breast cancer and node positivity, I think that an anthracycline followed by taxane regimen is absolutely standard. For a patient who has a lot of nodes and ER-positive disease and you're giving her chemotherapy, I think you also should use an anthracycline and taxane. And finally, CREATE-X. So CREATE-X is the study that was referred to before, 8 cycles of Xeloda in patients who had residual disease after neoadjuvant therapy. Big difference in disease-free survival, pretty big difference in overall survival, much bigger difference in women who had ER-negative disease than ER-positive disease. Now, I don't know about any of you, but when I give capecitabine to a woman with metastatic triple-negative breast cancer, it works once in a while, but it doesn't work nearly as well as all my patients with ER-positive disease. And so this I find very surprising. It hasn't been published, as was noted, and will the results hold up? Is it too good to believe? I don't know. I've only used this a couple of times in patients who had high-volume residual disease, and I'm very sorry to report that in both of those cases, patients recurred while they were still getting the capecitabine. And finally, scalp cooling. I think this is pretty cool stuff. I mean, it's not really cool. Oh, it is cool. But I think the big challenge here, and I'm sure this is true for those of you in either hospital-based or community-based practices outside of academic centers. It's certainly true for us in academic centers. We don't have the space to put people while they're getting their extra few hours of cooling, and we have to figure out some way of doing this. I think this is a major quality of life issue. I do think that this is something we should embrace. I don't think we have a choice, but the logistics around it are not inconsequential. So just the last slide, and sort of back to the beginning, in terms of these targets we have, it's going to require dedication and intelligence and creativity and collaboration and a whole lot of money. But I think that if we put it all together, we actually are truly poised to make very substantial improvements in the next decade. Thank you very much.